Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. It's my great honour to welcome Professor Anne Cools to the Glenohumeral podcast, and I'm so excited to have this discussion with you. I've been saving up some questions for our discussion, so welcome. It's such an honour for me to ask what is burning in the back of my mind. But before we start, can you share with us your physio journey? How did all this happen for you? Where did it start and how did you end up? I'm just really interested to hear that.
Well, it started a long time ago, that's for sure. And I wanted to start by thanking you, Margie, for inviting me for this podcast. It's really nice to discuss things with your peers, even if they are on the other side of the world, because you are in the middle of summer in the morning and I'm in the middle of the winter in the evening. So it's really fun to be here. So just to somehow describe where I come from. I graduated from physiotherapy university in 1986, which is the Middle Ages for many people. And then I started to be a clinician because my husband is also physio and my parents were both physios. So we worked together in the practice. But then a few years later, I got invited to do some teaching in a physiotherapy school. And there I really felt teaching is the thing that I really love. I like to share knowledge, share experience, bring new things to fresh students. And I started teaching in 93, I think. Then I turned, I tumbled into research. And for many years already, the upper extremity was for me more interesting than the rest of the body, in particular the shoulder. Not that the rest of the body is not interesting, but I think it's a hugely interesting joint part of the body. It's really a very nice topic to do your clinical work on and also your scientific work. So then my PhD was specifically on the role of the scapula, because when I started in 98, this was a bit the new hot topic, amongst others, with a paper from Ben Kibler in 98 with the title The Role of the Scapula in Athletic Shoulder Function. So I saw that and I really focused on what we had in the department as the methods or the tools for research, which was mainly EMG at that time, and the hot topic in the shoulder, which was the scapula. So I finished my PhD 2003, but I stayed at university ever since, so I'm still there. At this moment, I'm half-time. I have an assignment at university for teaching, but also for research. My other half time is divided between teaching international courses, which I also like a lot. It's really, it gives me a lot of satisfaction, and doing some clinical work. And in my clinical work, I only see shoulders, of course, but they are very often complex shoulders, which is frustrating for everyone, for the patient as well as for me. But it helps me to maybe treat the next patient better because of what I've learned from the complex patients, and also to share this with other colleagues in the field. And I will not work for 10 more years, maybe 5 more years, so my career will not last 20 more years.
It's so interesting, isn't it? Because I think that blend of working clinically and seeing those complex shoulders really helps to make the other work that you do so relevant to clinicians, isn't it? It's remembering what it's like at the coalface for so many people. So my plan is that we would do 2 podcasts. And in this first podcast, I really wanted to dig into the scapular EMG work because it's had an enormous influence on my practice. And I wonder, it really started based on some of that work from Ben Kibler is where it started, for your PhD.
Yeah.
Yes, yes, indeed. And that was more a clinical paper. I mean, there was no evidence. It was just
An
expressing his
idea.
opinion
Yes.
in scientific literature. And that was,
Yes.
I think, the start of many research lines all over the world
Mm,
on the scapula.
mm, mm. So these are the questions I want to ask you. Can we talk about upper trapezius? Because in my clinic, in my clinic, I take great care based on some of the EMG work I think you've done is around serratus anterior, lower trapezius, making sure people aren't overusing their upper trapezius. And I think I see that, with this push-up plus where people are maximally active, say in serratus anterior, but in that tilt that looks like upper trapezius activity, that might not be. What do you think? Am I should I keep paying attention to that? Tell me what your thoughts around those ratios, I guess, in
Mm,
the scapula.
yeah. So I think that the upper trapezius has been an enigma for the past 20
Mm,
years with very different opinions. I think that you have those who say, well, the muscle is too much activated, so we have to inhibit it during the exercises because it compensates too much for muscles that are actually too weak.
mm,
And then you have the others saying, well, maybe the upper trapezius is too active because it is too weak, so we should strengthen it.
yeah,
And I
yeah.
think there is some scientific evidence for the first statement, amongst others the studies that we did. But of course, our population was rather limited. It was overhead athletes, throwing
Yes.
athletes, and they indeed during maximal strength testing on the isokinetic device, they had more activity in the upper trap than the controls. And there is a lot of suggestions that the upper trap is too active because it's too weak, but there is no real evidence for that. And I think
Mm,
it might depend upon the patient because I think there's a huge difference between my overhead athletes, my swimmers, my gymnasts that indeed have a very dominant activity in upper trap. And then the
yes.
ones that maybe we will discuss in the second part of the podcast, the multidirectional instability patients, because they have this downward rotation of the scapula, so maybe they need upper trapezius training. So I think that
Mm,
the choice of inhibiting upper trap or rather training it depends on the patient that is in front of you. But
yeah.
I do believe that the muscles around the scapula and maybe by extension also in the shoulder joint itself, they they might react on an unhappy situation by working more or working less. And then the upper trap may work more in some occasions, like in overhead athletes, and maybe not enough in multidirectional stability.
And how do we tell? Like how do you tell for the clinician as a patient who walks in that it's got to be more than their position, that they're downwardly rotated, or like how are we going to know whether they are overactive and therefore, because I have this theory that sits around, if you're weakness then you would substitute, your brain just wants to perform the function, so there's a theory of substitution to get there because there's nothing else that's going to be able to help out. But how do you tell this? Like
In the
what's
clinic.
yeah, in the clinic, the patient
Yes, yes.
walks in. Do I inhibit this person's upper traps or do I facilitate them?
Yeah.
How are people to know?
Well, I think it's very difficult in the clinic to argue why the upper trap is working too much, because it's working too much or because it's weak. I
Yes.
would rather look at the type of patient. So I think if you have an
Okay.
elite gymnast or an elite swimmer, it works too much because it is really hyperactive because they use these muscles so much during their sports. But if you have a typical multidirectional instability, like I have seen a lot of Ehlers-Danlos patients,
Yes.
and
Yes.
they really have this quick downward rotation. In these patients,
Mm-hmm.
we have to train the
Mm-hmm.
upper trap. So it's more
Mm.
like the characteristics of the patients than how we can really objectively see or measure whether the muscle is hyperactive because it works too much or is hyperactive because it's too weak. I'm still a little
Yeah.
bit, but it's my background. I'm still a little bit in favor of the first statement. If it works too much, it means it's dominant. And of course, maybe it might be weak, but it's dominant at this time. And if we create more exercises to make this dominance even more relevant,
Yes.
then the disbalance will still remain. But of course, and maybe I'm jumping ahead to some more
Mm.
questions that you have. When we examined 20 years ago overhead athletes who had too much activity in the upper trap, not enough in the lower trap, not enough in the
Yes.
serratus, we
Yes.
created these ratios to
Yes. Yes. I want to.
inhibit the hyperactive
Yes.
ones and to activate the ones that are maybe less activated. And so these ratios, upper trapezius, lower trapezius, upper
Mhm.
trapezius, serratus, they were, I think at that time, it's like you get smarter every year. At that time, I think they were relevant. But in the meantime, I think that the more relevant ratios are between the muscles that have to move the scapula, the
Mm.
trapezius and serratus, whatever part of the trapezius,
Yes.
opposed to the ones that have a more postural role, which is pectoralis minor, levator scapulae.
Yes.
And I think that in between these two types of muscles, the ratios are more important.
Which leads me down to, well, we weren't going to go quite yet, but it leads me into some of, here I am holding my neck, looking
Yeah,
at some of these deeper muscles, because a lot of your work, earlier work, has been on like surface EMG, but more lately, can you explain some of these papers to me that you've done on the deeper muscles, because that is
yeah,
sort of changing then your
yeah.
thoughts on this.
Yes, yes. We did not do, I mean, me with my little shoulder group, we did not do neck
Yes,
muscles. We have other people in my department who do that. Let's say
yes,
that I was limited to the deep scapular muscles, which is pec minor, levator scapulae, rhomboids. And
yes.
what we could confirm then, and now this is research, is that the pec minor works more in patients with shoulder pain compared to controls when they do movements
Okay.
and exercises. So it's hyperactive. When we look at the practice, I think that many of us will agree that the levator scapulae is also very often hyperactive.
Mm.
Rhomboids, I'm not really sure. In my opinion, the rhomboids likes the levator scapula because they have a similar
Similar
direction.
line. Yes.
So, and they are really, I think they are meant to work against gravity when we don't move
Yes.
our arm. So they just, levator scapula is pulling against gravity to bring the
Yes.
scapula up. And the pec minor, I call it the backpack muscle. It's really pulling at the front like a backpack. And it
Okay.
pulls the coracoid forwards. And thanks
Yes.
to that, we keep the whole shoulder girdle steady, both sides, when we don't move. So they are, for me, muscles that work against gravity. And they have to relax when we move our arms. So the moment that you want to do this, you need your pec minor to relax because the pec minor performs an anterior
Mm.
tilting and we need
Mm.
posterior tilting. And the same
Mm.
for the levator scapulae. When it pulls at the medial side, it turns your scapula into downward rotation.
Yeah.
So you need to relax when you elevate your arm. But there comes the problem. What do we see in the clinic? Patients with shoulder pain, patients with neck pain, they have hyperactivity in these muscles.
Yes.
So apparently, pec minor and levator scapulae, they react on pain or on
Yes.
discomfort, on dysfunction.
It's
With
some kind of neural link, you're thinking, in the
I don't
presence of pain.
know.
No, I
So
know, but would you have any
yeah,
thought like why that's like as a reflex type action?
I don't know. So apparently, the muscles that work against gravity, they, and this is really subjectively what I say now,
Yes.
they protect, they have a protective reaction when we have pain by working
Yes.
more. But the
Okay.
result is the same, whether it's the cause or the consequence. The result is that these muscles are hyperactive. So I think
Yeah.
it's much more, with the knowledge that we know now, much more important to try to inhibit these muscles when we give exercises
Yes.
than
Okay.
the question of the upper trap and the serratus and the middle trap. I think the postural muscles versus the prime movers are more important.
Okay. And so that, I mean, I think because now consistently in the clinic, I don't always measure, there's a way of measuring pec minor. I'm sort of pretending I'm lying down, measuring up for, an anteriorly tilted, a tight pec minor. is that something that you think people should be measuring in the clinic? You should be looking at that position to see if
You
it's
should you should look at it, but I think it's not, we don't have really reliable and valid methods to measure it. What I do
Mm,
is indeed when people are lying on the back, I check
yes,
whether the position is more anteriorly, and then I
yes.
palpate. And just
Okay.
palpation of the muscle, you feel the difference between left and right, and the painful side is very often more tight. It's the same with pec minor. You just palpate it, but that's me, of course, as a clinician, not as a researcher.
Yes, but lots of this podcast really is for clinicians to help
Yeah,
them
yeah, yeah.
understand some of this amazing work that you have been doing to see how that could change their practice. And I think what I'm hearing from you is in supine that I will now check in here
Yeah,
for different differences and also check to levator scap to see
yeah.
if that there is an element of maybe contracture or tightness or yeah,
Yes.
I don't
Well,
know
we feel a
the word.
tightness. We don't know whether it's
Yes.
hyperactivity or tightness. I don't like to talk anymore about the pec minor like it is short. It's just,
Yes,
it works
okay.
too much. It works too much. And when you put,
Okay.
for instance, when you put people with the hyperactive pec minor, you put them side lying, you eliminate gravity. Suddenly, the pec minor is not the backpack muscle anymore because there is no backpack to
Yeah,
carry.
okay.
And very
Okay.
often it's much easier to move the scapula into a more posterior tilt because you relieve the pec minor from the burden of gravity.
That makes just so much sense now when I think about some patients that I've seen lately that I feel like they don't have full
No.
scapular range,
Yeah.
but inside lying, then that becomes much, much easier, doesn't
Yes.
it?
Yes. Yeah.
Do you think there's a way that we could conceptually group all these? Because now we're thinking about peak minor and rhomboids, levator scap with our upper trapezius, lower trapezius, serratus anterior. Is there a magic, I don't know, like an equation that would help us understand? Do you know what I mean? Like that
Yeah,
we
I
could,
know what you mean. Well, for that also we have to go back more than 20 years in time when
yes,
Ben Kibler described his three types of scapular
yes, yes,
dysfunction. I still look at it in several types of dysfunction, but I don't look through the skin whether I see these bony components like he described 20 years ago. I try to make a puzzle. So the combination of observation, of palpation, of
yes,
strength testing, whatever you do, then you say, well, I have a patient here maybe who has, and now I go back to his type 1, who has a hyperactive pec minor, maybe a weak lower trapezius, and that's another patient that the ones that has this dropped scapula, the downward rotation, which is in his classification the type 3, there you
mhm,
will have more a hyperactive levator scapulae. Maybe you will have a weak upper trap in these patients because they
yes,
lack upward rotation. So I
yes.
think that in the clinic, bringing all the pieces of the puzzle together is into a dominant type of dysfunction, regardless of what you see, type 1, 2, 3, but
Mhm.
just what you examine, combining observation with strength testing.
Yeah. And when I think what I'm doing currently in the clinic then is so limited because I am really looking. So I see somebody, and I'm interested to hear your thoughts. Somebody comes in with shoulder pain, they've got a painful arc. They're typically the ones I would go for scapular assistance. A cuff-related pain, and does the scapular assistance change their pain? If they're painful and resisted external rotation, does stabilizing their scapula change their pain? Then I tend to look for what I think is strength of serratus anterior lower trapezius. But actually, I'm just skimming the surface there, aren't I?
Well,
Yeah.
you don't know for sure whether it is the lower trap and the serratus anterior. You have to bring all the
Yes.
puzzles together.
Yes.
I'm a lower trap girl, so I really like middle and lower trap. I like everything that goes into external rotation. Um,
Yes.
I tend not to see that much serratus problems, but I also see a lot of problems in the pec minor. So for me, then it's okay. I need to strengthen the posterior side of the scapular muscles, whatever part of the trapezius it is, combined
Yes.
inhibition of the pec minor, or for instance, in what Kibler calls a type 3, I have to promote upward rotation, so I have to work here, and I need to
Yes.
decrease activity in the levator scapulae. But these are two different kind of patients, and I think it's really bringing the puzzle together based on what you see, what you feel in palpation,
Yes.
and what you can measure.
Yeah. And do you have any tips for clinicians there? Because I'm starting to realize, well, just talking to you as I knew I would, the complexity of this.
Yeah.
And I'm a shoulder therapist with 20 years of experience for younger therapists as because these complex patients still come in the door. That's where they start seeking care. What are your tips for them to in an
Well,
assessment and treatment?
only with respect to scapular involvement, right?
Yes, yes,
Yes. Okay.
yes,
So the
yes,
first thing is when you see scapular dysfunction or asymmetry, don't worry too much because scapular asymmetry is normal. We are not
yes,
symmetric. So when you see some scapular weird things that happen, be aware that it's not always abnormal. That's one. Now,
yes.
one way to check whether it is related to your shoulder pain or not is by performing the scapular testing. And by definition, the scapular tests that are published, like the scapular assistance test and the scapular reposition test, they are symptom reduction tests. So you start from a movement that is painful. You want to know whether somehow the scapula is the cause of that pain. So you try to correct something at scapular level, either the movement or the stability, and you do
Yes,
the test again. And if the scapular tests are positive, meaning that the symptoms go away or decrease, then you know at least the scapular dysfunction that you saw, which is not always abnormal, but it's
yes,
involved in the shoulder pain. So I think the
yes.
scapular testing is really important. And two tests were published, the scapular assistance and scapular reposition test, but you can create any scapular test by starting from a painful condition, either a
Mm-hmm,
position or movements. You change
mm-hmm.
something, and it could be anything. It could be, for instance, you say, well, my in my basic clinical examination, my external rotation against resistance is painful. Let
Yes,
me redo that with a better scapular position. Is this better? Well, then you
yes.
know that the scapula is involved.
Is
And then
involved.
I go actually to the shoulder symptom modification procedure from Jeremy Lewis that
Yeah,
really says, is this importance here? And
yeah.
once that you know that you have a link between your symptoms and the scapular dysfunction, then you can go into detail in measuring or palpating
Mm,
to see
mm,
what the details are of the problems.
mm. Why do you think some of the research doesn't support some of these tests, though? You know?
Because it's very difficult to do research on clinical things.
Yes. Tell me about
It,
that, because that's I know there's been lots of discussion around whether we should actually even bother with the scapula. Some people would
yeah.
say, I mean, I'm not in that camp, but I wonder the research doesn't necessarily always support us. Tell us about the
No,
difficulties there and
yes.
why you think that is, because I think that's important for clinicians to understand.
Yeah, I know. So I think on that level, there is a difference between the clinic and the research. In
Mhm.
research, we don't always have the tools, the standardization, the
Yes,
methods to really prove something that in the clinic we feel that is important.
yes,
So we feel that sometimes the scapula is important and sometimes not, but we don't have the research tools to prove that.
yeah,
In hypothetical, for instance, if you would like to prove that scapular dysfunction is a risk factor for shoulder pain
mm-hmm.
in the normal population, you might need to test 10,000 people
Yeah,
because otherwise your power of your study goes down. So
yeah,
sometimes the limitation is in the research itself. And that's why this is more a philosophical thing. When we think
mm,
about evidence-based practice, it's
mm,
not only the evidence that is important, but also your own clinical experience and your expertise, because
yeah.
some things will never be able to be proven.
It's so difficult, isn't it? First of all, this, like you say, the numbers that are required to adequately power your study to
Yes,
find this difference, and then to get all those people in, like
yes.
that's. So you think it's really the problem is in the research, not, which
It's
is
it's
challenging
in the
for us, isn't it?
in the limitation of research as such, we will never be able to solve that. We can do
Yes,
very good research on some levels, but there are
yes,
some issues like, is scapular dyskinesis really a cause of shoulder pain? It's
yeah,
nearly impossible to prove that ever. You
yeah.
need maybe 100 years to do that.
Yeah, but we don't have that in our lifespans, do we?
No.
And so you think the future then of scapular research, where is it going? What are
Well,
the questions? Because if it's not actually possible,
no, no.
where are we
So
heading?
yeah, actually, I'm going to start with an honest statement.
Mm,
I started scapular research in 1998 with my own research and my
yes.
PhD. And actually, we finished the scapular line in 2023.
Okay.
So we're not doing specific scapular research anymore at this moment, because
Yes.
for me, as a clinician also, many of my research questions that were possible to be answered, they are answered. So I started with what's the role of the scapula in shoulder pain in overhead
Mm-hmm.
athletes? And
Mm-hmm.
then the PhDs that I guided after me, they all
Mm-hmm.
looked at scapular rehabilitation exercises. And
Yes.
so we did a lot of studies, I think in 3 or 4 PhDs, looking at what is the optimal exercise to train a muscle or not to train a muscle if we want to
Yes.
inhibit. And
Yes.
this question has been, it's not answered totally, of course, because that's what's research like. It's never a 100%
Sure.
answer. But I think at this moment also the focus in research is not on the scapula anymore. So it would be not appropriate to focus too much on the local scapular level in the future research lines. There are other lines that are more relevant at this moment.
Do you think my concern is the problem people don't then appreciate its importance, and that if we don't keep focusing on it, we end up in a place where clinicians don't address scapular dysfunction. That's
Well, I think I understand and I appreciate people who criticize the role of the scapula. I have no problem with that. Of
yes,
course, the problem with extreme ideas, whether it's on social media or on conferences, is that it's a yes or a no, it's black or white, and we
yes,
need to stay
yes,
somewhere in the middle. So
yeah,
sometimes it's important and sometimes it is not. And I think in the every phenomenon in the physiotherapy goes with a flow where you have the hype,
yes.
everything, all the problems come from there, and the hype in the scapula, actually it's the year that the largest amount of papers was published on the scapula. It's 2013, and since
Okay.
then it went down
Listen,
again, which is good, but it should not go to zero. We should
no.
try to analyze in the clinic based on what we know from research. Is the scapula important in this patient or not?
There's a couple of things I want to before we wrap up, because there's a philosophical question here, isn't it? We are trying to do evidence-based practice. You are leading the research and have led in some of that space, and clinicians are trying to use the research to implement their practice, but there's limitations in research. I guess, are clinicians behind or in front of the research? Like what?
Yes, yes, yes. That's a very nice question because I think they are both. They are behind because they have to wait for the evidence to show that what
Yes.
they do is good, but they are also ahead because many of the research questions come from the clinic. So they very
Yes.
often do something from their gut feeling, from their clinical reasoning that is
Mm,
okay. And they can
mm.
do it until we, the researchers, will say, well, actually, what you do is rubbish or what you do is very good. So they are ahead and behind at the same time.
Yeah, which is incredibly empowering for clinicians, isn't it?
I hope so.
Because yeah, well, that's wonderful. There's two more things I want to ask you. There's sometimes I wonder, and this takes us right back to our upper trapezius, and now I'm in my cervical deep neck flexors, because we know that upper trapezius, at least my belief is that bilaterally will protract the chin, and so I pay a lot of attention
Yeah.
to cervical position when I am offloading upper or deactivating upper trapezius. Do you think then that's an important part of my, like, do you think I should continue doing that?
Yes, of course, because you say now I want to do this to unload or maybe less activate upper trap. I think everything is connected. If you
Yes.
use your neck flex, your deep neck flex in the correct way, and you have a
Yeah.
correct position of your head, then you will influence your levator scapulae and upper trap,
Mm,
and then you influence your scapula and you influence your shoulders. So of course it's all connected, and
yeah.
it's very often that we over time that we go to the next level, which is the more proximal part in the chain. Let's say that for 20 years we have been looking at the scapula. In one of the PhDs that I guided, we also looked at the cervical spine related to shoulder pain. So of course it is important, but there is not so much evidence,
Mm,
hard evidence, I mean, with
yes.
past studies to show that when you have weak neck flexors, that your shoulder will be injured. So we don't have that.
Yeah.
Yeah, but then we have to think about, like clinicians, of course, it's important to take everything into account, including
Yeah.
thoracic spine, cervical spine, the muscle activity here. I
Yes.
truly believe that the levator scapula can be a very naughty muscle because
Okay.
it pulls the scapula and it works against gravity. Like I often say, it avoids my scapula to land into my back pocket. So it's really pulling against gravity,
Yes.
but it
Yes.
needs to relax the moment that you move your arm. The same with the pec minor. I love the muscle just because I want to relax it. Because if you do this, but your pec minor is not saying, okay, I have to relax, you will be limited.
Okay. Thank you. That's going to change my practice. That's that's wonderful. Um, my final question for you is around kinetic chain, and so firstly, I mean, it's on that similar line. It has to be an important part of that, doesn't it? You know, and your scapula is that link in the kinetic chain. But again, the lack of research in this space
Yeah.
is challenging, isn't it? Because
Yes.
then we see, oh well, anyway. Tell me what your thoughts are around, because when
Well,
I hear then clinicians talking about pay attention to the kinetic chain, I wonder, well, how important is it, and
yeah.
how do we know how to do that properly?
Yes. So here again, there is a gap between the research and the clinic.
Yes.
In the clinic, we look at the kinetic chain for many years, also in athletes. And
Mm,
again, it's like a wave in physiotherapy. And
yeah.
where the scapula is going down, the kinetic chain is going up. Everything
Yes.
comes from the chain. And in the past, I think, so, let's say 10, 15 years ago, there were a lot of studies looking at how much percentage of the energy comes from the lower
Mm,
extremities or the trunk. And okay, these exist, but they are a little bit outdated.
yes.
At this moment, I think I um I was involved in a Delphi study on the importance of the kinetic chain with a
Hmm.
Spanish colleague, where it became obvious that there is so many opinions on the kinetic chain. It is important, but we cannot really give it a scientifically based connotation on what should we measure, what should we do, what is the ideal concept of a kinetic chain? Is it more a myofascial concept or an
Hmm.
anatomical concept or more an energetic one? And I
Yes.
have the impression the last few years that there is an increase in interest from a scientific point of view into the kinetic chain, with, amongst others, the Delphi study I just mentioned, but also there was a very good systematic review from uh, Richardson in 2020, already 4 years ago, on
Yes.
can we change muscle recruitment by implementing the kinetic chain? Then the answer is yes, we can. You can change the way muscles work by implementing less or more kinetic chain
Yes.
components. But when the question is, can we really make our patient better shoulder wise? I mean, in
Yeah.
view of function and pain, when we work in the kinetic chain, then the answer is we don't know. I don't know if you remember that we had this discussion or a quote from a participant in the conference in Rome last year in
Mhm.
ICSCT, where they say, well, everyone knows that you need to work in the kinetic chain for optimal rehabilitation. And then we all said, well, no, that's not proven. We all
Yeah.
think that it's important. But regardless of the fact that there is no real evidence for kinetic chain
Mm.
implementation, I think it's more fun to do for young people. And
Yes.
it also allows us to address kinetic chain deficits. So you will not make your shoulder better, but maybe your hip will be more stable and your mobility of thoracic spine will be better when you work in the kinetic chain. So I'm an absolute fan of kinetic chain implementation, but it's me as a clinician, not as a researcher.
Yeah. One of my concerns, or one of the things that I found interesting that I took from that conference, is we know that addressing kinetic chain will unload the rotator cuff or there's decrease activity. But some of the work that I do, that definitely in the initial stages, I think that's relevant. But then my practice has been about loading the cuff to make sure that it's sufficient for the task that it needs. So maybe I should do kinetic chain work in the beginning because it makes it easier for the cuff, and then ditch it later on and focus on cuff loading. Like, what are your thoughts around then unloading or loading rotator cuff on the back of that?
I think evidence is not really strong on that level. It's not like we have
Okay.
a million studies showing that the cuff is loaded or
Yes.
unloaded using the kinetic chain. I think kinetic chain should be used for what it is, to train the whole body, and not to
Yeah.
think too much about, oh, should I unload or load the cuff? Just
Okay.
address the kinetic chain without too much thinking about what it does on muscle activity levels, and definitely not what it does on pain and function. We did a small study that was not published. It was performed in COVID times, so we never had
Yes.
enough patients. And there we had one group training only the shoulder, a second group training the shoulder, but also the kinetic chain. So, for instance, performing some squatting exercises. And then the
Yes.
third group did some integrated exercises. And they all got better after 6 weeks, which is the good news. But there was no difference between the groups, so it doesn't matter. But the groups were
Yeah.
small, so it was not really a robust study design. So I think
Yes.
if we train the chain for now, we should do it because it's more fun and because you are able to address kinetic chain deficits, not because it's proven that it makes your shoulder better. But
Okay.
on the other side, there is evidence that kinetic chain performance is associated with sports performance. So
Yeah.
the stronger you are in your lower extremities, the better you perform in handball or in swimming.
Yes. Which makes sense, doesn't it, in
Yes,
terms of
yes, of
being able
course.
to produce power? Where do you think the research is going here then? What's where do you think that's through EMG work or
Yeah,
measuring
well,
different
no, I think
strengths
on that
or
level, but of course that's because the journals dictate what your research is, depending on what they want to publish or not. I think that
yes,
EEG studies on the level of kinetic chain, it's not so easy to publish anymore because they published some years on that. I think on kinetic chain, either a good clinical study is important,
yes,
showing that kinetic chain integration in your treatment is better than when you do isolated shoulder exercises.
yes, yes,
And besides that, I also think that kinetic chain testing, so the physical performance test, the functional
yes.
performance test, might, where you are also involved very into detail, maybe that's the next step. If we can prove that the kinetic chain is important because we measure it, that it's not functioning as well as we want it to, then we
Yes.
can argue whether it's necessary to train it.
Yeah, okay. By moving that space forward in terms of, because lots of those performance tests are entire body type
Yeah.
things, aren't they?
Yes. And
Um,
that's the nice thing about your test battery also. It's not only looking at shoulders, it's looking at the whole body. And maybe
mm,
we might call it functional testing or physical performance testing, but it's actually you measure the kinetic chain.
yeah, yeah. So interesting, isn't it? Um, we need to wrap this up, Anne, because I'm conscious of your time and I have loads of other questions to talk to you about in our second podcast. do you have any final comments that you think is important for clinicians to take home from listening to this podcast? What do you think for them? What are the key points that you want them to understand?
I think the key point is try to find out whether the scapular dysfunction that you see, observe, or measure, whether it is relevant to the symptoms that the patient has. If yes, treat it accordingly. If
Yeah.
not, accept it as a normal feature.
Yeah. Even though it looks a bit funny, don't
Yes.
worry about that if it doesn't influence their pain.
Yeah.
Yeah. Cool. Hey, well, thanks very much. That's been wonderful.
You're welcome.
And there's going to be some great, new ways for me thinking in the clinic. So I appreciate your time. That's great.
It was really nice also to talk about the scapula again.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget, you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via telehealth worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.